Hi, and welcome to the Dr. MEK Anesthesiology Podcast Series.
Yeah, thanks for having me.
In this deep dive, we're going to be focusing on anesthesia for carotid endarterectomy.
Sounds good.
Now, with our combined 14 years of experience in anesthesiology, we're hoping to shed light on this critical procedure and some of the nuances involved.
Right.
As always, this deep dive is for educational purposes only and is not a substitute for professional medical advice.
Of course.
Our discussion today is based on excerpts from two articles: Anesthesia for Carotid Endarterectomy, Virtual Library, and Anesthesia for Carotid Endarterectomy General or Loco-Regional, PMC.
Okay, great.
You are listening to the Dr. MEK series.
All right, so let's start with the basics.
Yeah, so when we talk about carotid endarterectomy or CEA,
Right, CEA.
what exactly are we dealing with?
Well, CEA is a surgical procedure to remove plaque buildup in the carotid arteries.
Okay, and the purpose of this is to prevent strokes.
Exactly. It's all about preventing those strokes.
Now, why is this so important for us as anesthesiologists?
Well, the challenge lies in managing the patient's physiology during this procedure.
To ensure adequate cerebral blood flow.
Yeah, that's the key.
That brings us to patient selection, which is crucial in CEA.
Absolutely.
So who are the ideal candidates for CEA?
The ideal candidates are symptomatic patients.
Meaning they have experienced symptoms like a TIA,
Exactly, a transient ischemic attack.
and they also have high-grade stenosis greater than 70%.
Right, in these cases, the benefits of surgery definitely outweigh the risks.
Okay, so that's pretty straightforward, but what about asymptomatic patients?
Yeah, that's where things get a bit trickier.
The decision-making becomes more complex there.
For sure, for asymptomatic patients, CEA is only considered when the perioperative morbidity and mortality rate is very low.
Less than 3%.
Yeah, ideally less than 3%, and the patient is deemed a low anesthetic risk.
So a very careful risk-benefit analysis is needed.
Absolutely. We need to be very cautious with those patients.
Now let's move on to the heart of the matter, the anesthesia options available.
Okay, so we have two main options.
General and loco-regional anesthesia.
Right, and both approaches have their own pros and cons.
And the choice really depends on various factors.
Exactly. Patient-specific factors and the overall surgical plan.
So let's start by breaking down general anesthesia.
Okay.
What are some of the advantages that make it suitable in CEA cases?
Well, one major advantage is cerebral protection.
Okay.
Many anesthetic agents we use in general anesthesia can actually reduce the metabolic demands of the brain.
So that's beneficial during carotid cross-clamping.
Exactly. It offers that extra level of protection.
So we're essentially putting the brain in a state of reduced activity.
That's right. Minimizing the risk of damage during that critical period.
Okay, and what about control over ventilation? Is that an advantage?
Absolutely. With general anesthesia, we have complete control over the patient's ventilation.
So we can precisely regulate oxygen and carbon dioxide levels.
Exactly, which is vital for maintaining that cerebral blood flow.
So it sounds like a very controlled environment.
It is, which is reassuring in such a delicate procedure.
But you mentioned there are some disadvantages as well.
Right, so one of the main drawbacks is the potential for labile blood pressure.
Labile blood pressure meaning fluctuations.
Exactly. And maintaining a stable blood pressure is critical during CEA.
But general anesthesia can make that challenging sometimes,
It can.
especially since many of these patients have underlying cardiovascular disease.
That's right. It's a major consideration.
And this brings us to another disadvantage, the risk of myocardial ischemia
Yeah, we need to be very careful about maintaining blood flow to the heart muscle.
throughout the entire procedure.
Yes, the heart is just as important as the brain in this scenario.
So it's like a balancing act, ensuring the well-being of both organs.
Absolutely a delicate balance.
And finally, general anesthesia masks any neurological issues during surgery,
Right, if a neurological event happens, we might not know until after the procedure.
which could delay any crucial interventions.
That's a significant concern and why we monitor so closely.
Now let's switch gears and talk about loco-regional anesthesia.
Okay, so loco-regional anesthesia for CEA usually involves either a cervical plexus block or a cervical epidural.
And this is in contrast to general anesthesia where we're numbing the entire body.
Exactly. Loco-regional focuses on a specific region.
Okay, so what are some of the advantages of this approach?
Well, one of the biggest advantages is that we can monitor the patient's neurological function throughout the surgery.
Because they're awake.
Exactly. They're awake and can communicate, which allows us to directly observe motor function, speech, and cognition.
So we have a real-time assessment of their neurological status.
That's right, a very valuable safeguard.
And because the patient is awake, there's often less need for shunts.
Yeah, those tubes that bypass the blocked artery.
So we're minimizing the risks associated with shunt insertion.
Exactly. And another advantage is that we typically see better cardiovascular stability.
So loco-regional addresses some of those concerns we talked about with general anesthesia,
It does. The stress response associated with surgery is usually dampened.
leading to a more stable blood pressure.
Exactly.
But loco-regional has its limitations as well, right?
It does. Patient suitability is one major concern.
What do you mean by that?
Well, some patients may be too anxious for this type of anesthesia.
Or they may have anatomical challenges.
Exactly, that make loco-regional difficult.
And there are also potential complications.
Yes, things like inadvertent intravascular injection or nerve blocks can happen.
So meticulous technique and a thorough understanding of anatomy are essential.
Absolutely, those are non-negotiables.
So it's clear that both general and loco-regional have their place in CEA.
They do, each with their own unique advantages and disadvantages.
And choosing between them requires a careful consideration of the patient's individual circumstances.
Couldn't agree more. It's a case-by-case decision.
Now let's move on to perioperative management.
All right, so this encompasses the care we provide before, during, and after surgery.
And this is really crucial for optimizing patient outcomes.
It is. It's a holistic approach.
So let's start with preoperative management.
Yeah.
What are some of the key things we focus on?
Well, first and foremost, we do a very meticulous patient evaluation.
What does that involve?
We gather a detailed medical history. We look at their current medications, their overall health status.
So we're essentially trying to identify anything that might increase the risk of complications.
Exactly. We're trying to be as proactive as possible.
For instance, controlling hypertension is critical.
It is. High blood pressure can really impact both cerebral and cardiovascular health during surgery.
So ensuring the patient's blood pressure is well managed is a top priority.
Absolutely, even before they enter the OR.
Oh. Now, what about other conditions like diabetes?
Well, diabetes management is equally important.
Because fluctuations in blood sugar can also have detrimental effects.
We want to avoid those at all costs.
And I imagine if the patient is a smoker, we strongly encourage them to stop.
Absolutely. Smoking cessation is always beneficial, but especially in the context of surgery.
Okay. And what are the benefits of quitting smoking?
Well, it improves blood flow, reduces respiratory complications, and enhances wound healing.
So it's all about minimizing those risk factors.
Exactly, stacking the deck in the patient's favor.
Now let's talk about medication management, which is another critical aspect of preoperative care.
Okay, so we need to figure out which medications to continue, adjust, or temporarily stop.
Give me an example.
Well, with antihypertensives, we generally advise patients to continue taking their regular medications.
Except for ACE inhibitors and ARBs.
Right, those are the exceptions.
And why is that?
They can cause a sudden drop in blood pressure during surgery.
Which we obviously want to avoid.
Absolutely. Maintaining stable blood pressure is key.
What about antiplatelet therapy?
So those are usually continued as well.
Like aspirin or clopidogrel?
Exactly. We want to prevent blood clots.
But clopidogrel can increase bleeding risk.
It can, so we need to carefully consider that.
So we're weighing the benefits of preventing clots against the risk of bleeding.
That's right. It's a balancing act.
Okay, and beyond medication management, you mentioned patient education is also important.
It is. We want to empower the patient with knowledge about the procedure.
To alleviate anxiety and improve compliance.
Exactly. An informed patient is a more relaxed patient.
So what kind of information do we typically discuss?
We explain the whole surgical process, the anesthesia plan, the use of neurological monitoring, and any potential discomfort they might experience.
So setting realistic expectations and building trust.
That's the goal. We want them to feel informed and comfortable.
You are listening to the Dr. MEK series.
We'll be right back to continue our discussion after a short break. So we were just discussing the importance of preoperative management for patients undergoing CEA.
Right, and how crucial it is for optimizing patient outcomes.
Absolutely. Now let's move on to the intraoperative phase.
The main event.
Exactly, where our decisions have a direct impact on the patient's well-being.
Now, we talked earlier about blood pressure control and how critical it is throughout the procedure.
Right. Maintaining hemodynamic stability is key.
But the blood pressure targets we aim for can differ based on whether a shunt is used during CEA.
That's correct. Let's first consider a scenario where a shunt is being used.
Okay, so in those cases, we generally aim to keep the blood pressure at or slightly above the patient's baseline.
Precisely. We're not aggressively raising the blood pressure because the shunt helps maintain that cerebral perfusion.
So the shunt acts as a safeguard, ensuring continuous blood flow to the brain while that carotid artery is clamped.
Exactly. It's like a detour for the blood.
Makes sense. But what about situations where a shunt isn't being used
In those cases, we might need to target a higher blood pressure.
to compensate for the reduced flow through the blocked artery?
Exactly. We need to make sure enough blood is reaching the brain through the remaining vessels.
But we don't want to go too high.
Right, of course not. Excessive hypertension can lead to other problems like bleeding.
So it's about finding that sweet spot, that optimal blood pressure range for each individual patient,
Precisely, balancing cerebral perfusion with the risks of hypertension.
and achieving this precise blood pressure control requires a multifaceted approach.
It does. We use a combination of techniques.
Like what?
Well, we adjust fluid management, we use vasoactive medications, and we meticulously monitor the patient.
So let's break those down. Starting with fluid management, how does that help us control blood pressure?
By adjusting the amount of intravenous fluids the patient receives, we can directly influence their blood volume.
And therefore their blood pressure.
Exactly. It's a basic principle of fluid dynamics.
Okay, and what about vasoactive medications?
These medications allow us to fine-tune the blood pressure more directly.
Because they can either constrict or dilate blood vessels.
Exactly. We can give a medication that will either raise or lower blood pressure depending on what the patient needs.
And all of this is guided by continuous monitoring, right?
Absolutely. We're constantly watching the patient's blood pressure, heart rate, and other vital signs.
And using that information to make real-time adjustments.
It's a dynamic process that requires vigilance and expertise.
Speaking of vigilance, let's talk about neurological monitoring during CEA
Right. This is where we really need to be on our toes.
to detect any signs of cerebral ischemia.
Exactly. And we have a range of monitoring tools at our disposal.
Like what?
Well, one common approach is electroencephalography, or EEG.
EEG measures the brain's electrical activity, right?
It does. And changes in those EEG patterns can alert us to potential ischemia.
So it's like listening in on the brain's electrical signals.
That's a good way to put it.
And are there other methods we use for neurological monitoring?
Yes. We often use somatosensory evoked potentials, or SSPs.
How do those work?
With SSPs, we stimulate a peripheral nerve, usually in the arm or leg.
Yeah.
We measure the electrical response in the brain.
Oh,
If there's a delay or if that expected response is absent, it could suggest a disruption in the neural pathway.
potentially due to ischemia.
Exactly.
So we're essentially tracing the electrical signal as it travels from the periphery to the brain.
That's right, making sure the pathway is clear.
And are there any other techniques we use for neurological monitoring?
Yes. We also frequently use transcranial Doppler ultrasound, or TCD.
Now, TCD uses sound waves to assess blood flow.
Correct. It allows us to measure the velocity of blood flow in the cerebral arteries.
So if we see a decrease in velocity, that could indicate compromised perfusion.
Exactly. And that would suggest a need for intervention.
And then there's near-infrared spectroscopy, or NIRS.
Right. NIRS is a non-invasive technique that measures the oxygenation of brain tissue.
By shining near-infrared light through the skull.
That's right. It gives us a direct measurement of how much oxygen is reaching the brain.
So we're really using all of these tools together to paint a complete picture of the brain's health doing CEA.
Exactly. And this is all in addition to our meticulous clinical assessments, especially in patients who are awake under loco-regional anesthesia.
Now let's go back to the decision of whether or not to use a shunt during CEA.
Right. As we discussed earlier, it's a case-by-case decision.
But are there any general principles that guide that decision-making process?
Absolutely.
Ah.
One of the primary factors is the degree of carotid stenosis.
Meaning the more severe the blockage, the more likely we are to use a shunt.
Generally speaking, yes, but it's not always that simple.
So other factors come into play as well.
Yes. The patient's collateral circulation is another crucial consideration.
Now, collateral circulation refers to those smaller blood vessels that can provide alternative routes for blood flow.
Exactly. And if a patient has good collateral circulation, they might be able to tolerate cross-clamping without needing a shunt.
So we need to assess their baseline cerebral blood flow to see how robust their collateral circulation is.
Exactly. We want to make sure the brain is getting enough blood flow even when that carotid artery is clamped.
And what about the patient's overall health?
That's important too. Patients with significant comorbidities, like heart disease or lung disease, might be at higher risk for complications from shunting.
So it's a balancing act.
It is. We weigh the potential benefits of the shunt against the potential risks for each individual patient.
And while the surgeon ultimately makes the call about whether or not to use a shunt,
We as anesthesiologists play a vital role in providing them with the information they need.
it's a team effort.
Absolutely. We work together to make the best decision for the patient.
Now let's shift gears a bit and talk about managing potential emergencies during CEA.
Right, because emergencies are always a possibility in surgery.
And they can escalate quickly if not handled properly.
Exactly. So we need to be prepared for anything.
What are some of the common emergencies we might encounter during CEA?
One of the most concerning is a sudden drop in blood pressure or hypotension,
And why is that so worrisome?
because it can compromise blood flow to the brain.
Leading to ischemia and potentially neurological damage.
Exactly. So prompt recognition and intervention are absolutely crucial.
What steps do we take to address a sudden drop in blood pressure during CEA?
First, we need to figure out what's causing it.
Is it blood loss, a reaction to the anesthetic, or a cardiac event?
Exactly. Once we know the cause, we can tailor our treatment.
So if blood loss is the culprit, we focus on fluid resuscitation and possibly blood transfusion.
Right. We need to restore that circulating volume.
And if it's a reaction to the anesthetic,
We might adjust the anesthetic or give medications that raise blood pressure.
and if it's a cardiac event.
Then we'd initiate the appropriate cardiac interventions.
So it all comes down to identifying the root cause and addressing it swiftly.
Exactly. Time is of the essence in these situations.
Now, another emergency we need to be prepared for is a sudden change in the patient's neurological status.
Right. That could manifest as weakness, speech difficulty, or a change in their mental state.
And that could signal a stroke, a hematoma, or some other serious complication.
Exactly. So we need to be very vigilant.
What do we do if we see those signs?
We immediately alert the surgical team.
So communication is key.
It is. We need to work together to figure out what's going on.
And would we consider getting some imaging studies done?
Yes. Depending on the situation, we might get an emergent CT scan to pinpoint the cause of the neurological change.
So managing emergencies during CEA really requires a high level of expertise.
It does. We need to be able to think on our feet and act quickly.
And having a thorough understanding of the procedure and its potential complications is crucial.
Absolutely. We need to be prepared for anything.
And we need to be able to communicate effectively with the surgical team.
Right, because it's a collaborative effort.
Now let's move on to the final stage of care postoperative management.
Okay, so after the surgery is complete, our focus shifts to ensuring a smooth recovery and minimizing complications.
So we're still not out of the woods yet.
Not quite. We need to be just as vigilant in the postoperative period.
You are listening to the Dr. MEK series.
We'll be back shortly to wrap up our discussion on postoperative care.
So we're back now to talk about the last but equally important part of care in CEA.
Right. Postoperative management.
So after the surgery is done, our focus shifts to making sure the patient recovers smoothly and that we minimize any risks of complications.
Yeah, exactly. Postoperative management is where we shift from that intense intraoperative vigilance to ensuring a smooth recovery for the patient.
And it all starts with monitoring, right?
Absolutely. Continuous monitoring is key.
We've been talking about monitoring a lot, but how does our approach to monitoring change after the surgery?
Well, our top priority is still maintaining that stable blood pressure.
Right. We've talked about how crucial that is throughout the entire process.
Exactly. Both hypertension and hypotension can have serious consequences even after the surgery is over.
We've gone over the risks of hypertension and the danger of hyperperfusion syndrome, but hypotension can be just as bad, right?
Oh, absolutely. Hypotension can reduce blood flow to the brain, which can lead to ischemia, especially in patients who have problems with their cerebral autoregulation.
So again, it's all about finding that perfect balance.
Exactly. We're constantly monitoring their blood pressure, adjusting fluids, using medications, anything to keep it in that safe range.
And I imagine neurological monitoring is just as important after surgery.
Absolutely. We're always checking their mental status, motor function, and looking for any new problems with their senses or speech.
Because even the smallest change could be a sign of a bigger issue.
Right. It could indicate a stroke, a hematoma, or other complications, so we need to catch them early.
And speaking of the surgical site, we're also keeping a close eye on that too, right?
Of course. We need to make sure the wound is healing well and that there are no signs of infection or bleeding.
And we've talked about how dangerous a hematoma can be, especially if it starts to compress the airway.
Exactly. A hematoma in the neck can quickly become life-threatening. We need to be able to recognize those signs immediately.
So what do we look for?
We're checking the wound for any swelling, redness, or drainage, and we're also feeling the area to see if it's tender or if there's any fluid buildup.
So both visual and physical checks are essential.
Absolutely. We're leaving no stone unturned.
And of course, we're also managing the patient's pain.
Right. We want to make sure they're comfortable, but we're also mindful of the potential side effects of strong pain medications.
Especially opioids.
Exactly. They can cause breathing problems and constipation, which can be especially problematic in these patients.
So what's the best way to manage pain after CEA?
We often use a multimodal approach, meaning we combine different pain relief strategies.
So what does that look like in practice?
Well, we might use nonsteroidal anti-inflammatory drugs, or NSAIDs, to reduce inflammation and pain.
And NSAIDs have that added benefit of tackling inflammation at the surgical site.
Precisely. We might also use regional anesthesia techniques, like nerve blocks, to provide more targeted pain relief.
And those nerve blocks can really help reduce the need for opioids.
Exactly. And we might also consider other medications like acetaminophen or even gabapentinoids to help with pain control.
So it's really about customizing the pain management plan for each individual patient.
That's right, finding what works best for them.
And as they recover, we gradually transition them from IV pain medications to oral medications.
Yes, that gradual transition is important for their comfort, and it helps them regain independence in managing their pain.
And we make sure they know how to manage their pain once they go home, right?
Absolutely. We give them clear instructions about their medications, potential side effects, and when to seek medical attention.
So patient education is a really important part of postoperative care.
It is. We want them to be active participants in their recovery.
Now, as we wrap up this deep dive on anesthesia for carotid endarterectomy, are there any key takeaways you want our listeners to remember?
Well, I think the most important thing is that attention to detail is absolutely crucial in every aspect of care. From the initial evaluation to managing their vital signs and watching for complications, every step requires a deep understanding of what's going on.
You're really emphasizing the expertise that's required in this field.
Absolutely. It's not just about putting the patient to sleep. It's about actively managing their physiology throughout a very delicate procedure.
And you've also highlighted the importance of teamwork.
It really does take a village. Everyone from the surgeons to nurses and respiratory therapists plays a critical role.
And of course, we can't forget the human element.
Absolutely. Behind all the technical details and physiological challenges are real people with real fears and concerns.
And taking the time to listen to those concerns and reassure them can make a world of difference.
It builds trust and helps alleviate anxiety.
Anesthesia for carotid endarterectomy requires skill, vigilance, and compassion.
It does, and it's a field that's constantly evolving with new techniques and technologies emerging all the time.
Which is why continuous learning is so important.
Absolutely. We need to stay up to date to provide the best possible care for our patients.
You are listening to the Dr. MEK series.
We encourage you to subscribe to our channel and hit the bell icon for updates on the latest in anesthesiology.